The first one will deal with some introductory things, most of that you already know from your preclinical days. The second class will be on acute renal failure. The third and fourth class will be on chronic renal failure. The fifth class will be on renal transplantation. It's not much into your curriculum, but I will deal with some generalized overview and some basic facts that every medical students nowadays should know. And on the sixth class, we will recap the whole thing and do any doubt clearing if required by you. That's the brief agenda. Okay. Now, first clear two terms. One is nephrology and the other is urology. Both sound the same, but actually nephrology deals with the medical aspects of the diseases concerning the kidney and the urinary tree, and urology deals with the surgical aspects. So, if you come across some urologist, he is not basically a medical kidney specialist, he is a urosurgeon actually, and a nephrologist is a medical person who deals with the medical aspects of the kidney. In these 6 lectures, we will deal with mainly the medical points. Now, today we will just take some anatomical hard facts, some investigations and some symptomatology of the nephrology part. The first slide is on surface anatomy of the kidney. Can you see it from the back? I think you could do better to come inside. Okay. The kidneys are, the human kidneys in an adult are 2 oblong shaped organs that are set in the back side of the abdominal cavity retroperitoneally. It is not in the peritoneal cavity, it is set in the back. On either side of the vertebral column, it actually lies at the level of twelfth rib to L3 rib, 12th vertebra to L3 vertebra. This is the position. The length is about 10 to 14 centimeter in an average built adult, 11 to 14 centimeter. The right side kidney is slightly lower, you know, about 1.5 centimeter lower than the left kidney. Why? Because it is pushed downwards by the liver. The 12th rib actually acts, almost serves as a axis for the kidney. This is the 12th rib. So, if from the back side you want to palpate the kidney, you have to press at this point. This is the renal angle. When you palpate an abdomen from the back, you press at the junction between the 12th rib and the erector spinae muscle, and this point is the renal point, right renal point and left renal point. If you push with your thumb, you can elicit a painful sensation if the kidney is diseased. Suppose there is a pyelonephritis or some renal cell carcinoma or some acute abscess, renal abscess, then you can definitely elicit a painful sensation by pressing in this point, that is the renal point. Okay. As they are retroperitoneal structures, they do not move with the respiration. This is one major point by which you differentiate between an enlarged spleen and an enlarged kidney. Suppose there is a lump in the left hypochondrium and the examiner is asking you, how can you differentiate between an enlarged spleen or an enlarged kidney? How can you be sure? You are telling that this is enlarged kidney. How can you be sure? There are 4 points. One is the axis of the spleen will be directed towards the right iliac fossa. It will be oblique, but the kidney enlarges downwards. In the flank, you can palpate it like this. This is number 1 point. Number 2 and very important point is the splenic notch. When you are palpating the anterior border of the lump, if it is the spleen, then you can definitely find a notch-like thing, that is the typical splenic notch, and that differentiates from the kidney, enlarged kidney. The third one that I was telling, that is the lump. If the lump is moving with respiration, then it's spleen, because it's a intraperitoneal structure. And if it does not moving with respiration, then it's kidney, more likely to be kidney, because it's a retroperitoneal structure. Okay. I'll come to it later. This is the quintessential nephron you have been seeing since your class 9 days. Let's look at it once more. This is the renal artery from here. An afferent arteriole forms the glomerulus, then goes out as the efferent arteriole, does the arterial plexus around the nephron, finally forms the renal vein and goes out. Of the nephron, this is the Bowman's capsule, taking within it the glomerulus, then the proximal convoluted tubule, the loop of Henle, the distal convoluted tubule, the collecting tubule, which finally drains into the ureter via the pelvis. Of the loop of Henle, there is a thin walled segment, this is thin walled segment, and this is the thick walled segment. There are functional differences and significance of this thin walled segment and thick walled segment, that we will come on later. If we look at it more macroscopically, then the kidney has got, if we take a sagittal section, coronal section actually, is bound outwards by the fibrous capsule. This has got innervation from the T12, T11, T12 and L1 dermatome. So, if there is any painful sensation from this area, that is the fibrous capsule, you can find the pain in that dermatome, T11, T12, L1 on that area. This is the renal cortex, this is the renal medulla. These are the renal pyramids formed by the collecting tubules, and in between there are the renal columns. These things are the renal columns, the lighter ones, interspersed between the renal pyramids. The tip of the renal pyramids, these are the renal papilla, they drain into the minor calyx, which coalesce to form the major calyx, and the major calyx finally make the renal pelvis, draining into the ureter. This is the section of the kidney. The ureter from either side drains into the urinary bladder. In the bladder, there is a layer of smooth muscle, that is detrusor muscle, which causes the bladder contents to go outside. This is under involuntary control. The ureters open into the bladder in an oblique way, not directly like this, in an oblique way. Why? When the detrusor muscles contract, this obliterates the inlet of the ureter, so that urine cannot regurgitate out upwards. Okay. This is the outlet. Here the urethra originates. It has got three parts: the prostatic part, prostatic urethra, there is the membranous urethra, and finally the spongious urethra. There are two sphincters, that is rings of smooth muscles. This one is the internal sphincter, which is situated at the bladder outlet, and this is the external sphincter, which is situated in the membranous part. This one is involuntary control, this one is controlled by the pudendal nerve, S2, S4. Okay. And this is the spongious part. This is the external urethral meatus. This is internal urethral meatus, this is external urethral meatus. So, this is grossly the structure of the urinary tree. a bit larger picture of this. Again, the ureter, the detrusor muscle, this is the fibrous capsule, the detrusor muscle, these are the ureteric orifices, the internal bladder neck level internal urethral meatus, the spongious part, and the external urethral meatus. This is the female urinary tract. Here, the urethra is much shorter, about 4 cm in length. At the level of the bladder neck, there is the internal urethral sphincter. At the outlet, there is the external urethral orifice, and this is the urogenital diaphragm, which takes a major part in urinary continence. In yesteryears, when there was the issue of multiparity, a woman used to bear quite a number of children, and there was always the chance of prolonged labor, difficult labor, and these used to damage the urogenital diaphragm. So, after middle ages, say 35, 40 years, most women tended to become incontinent. We will come to incontinence few minutes later. What happened? The ladies could not control their urinary flow effectively. So, whenever there was some stress, say the patient is coughing violently, there was the chance of leakage of urine because the valves were not continent. In short, the anatomy of the urinary tree that we will deal with in our later lectures. Now, what are the investigations that we usually resort to for a urinary case? The symptoms, let us come to the symptoms first. There are typical symptoms for the urinary tree. Number one is dysuria. What is dysuria? This is simply, this is painful micturition. The commonest cause is urine infection in any part from kidney to the external meatus. In any part, an inflammation may give rise to a dysuria. This is often associated with a fever, particularly when it is above the level of the bladder. That is called upper urinary tree, and the lower urinary tract, that is bladder, prostate, urethra. This is the lower urinary tract. If the infection is in the upper urinary tract, then usually it is associated with a fever. The fever is to the tune of 38°F, that is above 99. There is typical chill and rigor. Maximum pyelonephritis cases are associated with severe chill. প্রচন্ড ব্যথা লাগবে পেশেন্টের, ঠান্ডা লাগবে, কাঁপুনি হবে, কাঁপুনি কন্ট্রোল করা যাবে না, দুটো তিনটে কম্বল দিও, that cannot be controlled. Number one. Number two is there is often pain in the flanks, depending on which side is affected, right side or left side. The flanks are painful. If only the flanks are painful, then most likely the infection is in the upper urinary tract, that is above the level of the bladder. If the pain radiates to the penis or the external urethral meatus, or in case of females to the labia, then the infection is more likely to be in the lower urinary tract. And if the hole is involved, you will pain all over. You will see pain all over. So, from the level of pain, we can roughly get an idea about which part of the urinary tract is affected by the infection. What are the other causes of dysuria? Urosepsis is commonest cause. Okay. Next thing is, if there is a stone, a renal calculi, it has slipped from the kidney, from the pelvis, and it is lodged somewhere around the ureter or just above the bladder. Then there will be a severe pain, that is renal colic. What's the nature of the colic? It's not persistent throughout. It's a wavy pain. The pain becomes severe, the patient tosses up in the bed, and slowly the pain goes away. After some interval, it comes again. This wavy nature is called a colic pain, and renal colic or ureteric colic is one of the most severe colic pain that is known to human. In an acute stage, the patient almost tosses up in bed. ছটফট করতে থাকে, সোজা হয়ে বসবো না বেঁকে যাবো না শুয়ে পড়বো না উবুর হয়ে যাবো, পেশেন্ট ক্যান ডিসাইড, এত ব্যথা হতে থাকে, কোনো পজিশন হি ডাজন্ট গেট এনি রিলিফ। এছাড়া কি হতে পারে, কোনো কারণে ইফ দেয়ার ইজ আ হেমারেজ in the upper urinary tract somewhere in the kidneys or in the ureters, that hemorrhage may give rise to form some blood clots, and the blood clot while passing through the ureter may give rise to colic pain. These are the common causes of a dysuria and a renal colic pain. Next is hematuria. What is hematuria? Passage of blood in the urine. The color of the urine may be of different types. It may be pinkish, it may be frank red, it may be blackish. When the urine is pinkish, then that means the amount of blood that was put out was rather small. So it has been diluted by the urine and the color is pinkish, not very deep. When the bleeding is rather large, then it may be more red or it may be simply almost the blood is coming out through the urine. That occurs due to any tumor, any infection, any ulcer along the upper urinary tract or the lower urinary tract, anywhere. A renal cell carcinoma or an impacted stone may give rise to such sort of hematuria. Another very important cause of hematuria, though it is not very common, is IgA nephropathy. IgA nephropathy typically presents with frank hematuria, and this gives rise to nephrotic syndrome in the adults. There are other systemic causes that are not particularly limited to the urinary tree, like coagulation disorders. Any coagulation disorder that gives rise to mucosal hemorrhage may be associated with the hematuria. Okay. Next are the voiding problems. I missed another thing, that is, though that is not very common, but it's a interesting thing, and you can have it when you go to PG entrance days. In MCQ questions that is often given, there is a disease where the urine when passed, it's clear. You keep it for some time and it becomes anchovy sauce like or darkish. That is typical of acute intermittent porphyria. An urine which is clear on passage and becomes dark after some time on storage, that is acute intermittent porphyria. It is quite a rare condition. Okay. When a clear urine becomes just a bit cloudy, it denotes there are pus cells in the urine. Any gross infection in the urine may put the urine a cloudy. Okay. Next is the voiding problems. The urine accumulates in the bladder. When there is about 250 to 350 ml of urine, then you have the sensation of the bladder filling. As the amount increases, you gradually feel an urge to urinate. Till 450 to 600 ml, you can control that. Then it becomes almost unbearable to hold it. Depending on the person's threshold, he cannot hold it anymore. And after 800 to 850 ml, it becomes almost impossible to hold it anymore, and the patient maturates unless he gets an opportunity to do it senilely. So, there is the control to hold the urine is by parasympathetic control, and the urge to urinate comes from the parasympathetic area. What are the abnormalities that may be found? These are mainly lower urinary tract symptoms. There is a term LUTS, lower urinary tract symptoms. Of the LUTS symptoms, apart from the hematuria and dysuria, the major things are all the voiding symptoms. What are they? Number one is hesitancy. পেশেন্টের পেচ্ছাপ পাবে কিন্তু করতে গেলে হতে চাইবে না, বেরোচ্ছে না পেছন, এটা হচ্ছে হেজিটেন্সি। নেক্সট ইজ স্ট্রেনিং, patient strains to micturate but it still is not coming. Then it starts intermittent flow, টানা পেচ্ছাপ করতে পারছে না, খানিকটা হচ্ছে একটু থেমে যাচ্ছে বা আস্তে হয়ে যাচ্ছে, আবার স্ট্রেন করছে, আবার খানিকটা হচ্ছে থেমে যাচ্ছে, দিস ইজ কল্ড ইন্টারমিটেন্ট ফ্লো। যখন ইন্টারমিটেন্ট হচ্ছে না, ইট বিকামস আ স্লো ফ্লো, হি ইজ পাসিং ইউরিন বাট ইন আ ভেরি স্লো ম্যানার with a very poor stream. When it's completed, the patient gets the feeling of incomplete evacuation. পুরোটা যেন হলো না, কিছুটা যেন রয়ে গেল। This is sense of incomplete evacuation. What is the other thing? Dribbling of urine. পুরোটা হয়ে যাওয়ার পরও ফোঁটা ফোঁটা করে একটু একটু করে পেচ্ছাপ হচ্ছে। All these together constitute the lower urinary tract symptoms, and this is very typical of benign hyperplasia of prostate that occurs in the elderly male patients. There are other things, that is incontinence. Incontinence has got three terms. One is stress incontinence, one is urge incontinence, and the other is overflow incontinence. Urge incontinence is stress incontinence is the patient mictures with some stress, like as I said earlier, patient violently coughs and there is leakage of urine, that is stress incontinence. Urge incontinence is পেচ্ছাপ যখনই পাচ্ছে 350 ml 350 ml 450 ml ইউরিন হয়েছে, he should be able to hold it but he can't. Here this is urge incontinence. Whenever the patient feels the urge, he can't hold it anymore. This is urge incontinence. And what is overflow incontinence? In some patients, especially in elderly patients who have got a chronic bladder retention, benign hyperplasia prostate আছে, partial obstruction আছে, ইউরিন ভালো মতো ক্লিয়ার হতে পারে না, আস্তে আস্তে একটু 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 করে ব্লাডারে সবসময় ইউরিন জমে থাকে। অ্যাজ দ্য টাইম পাসেস, যত দিন যায় আস্তে আস্তে ব্লাডারে কিছুটা ইউরিন সবসময় জমে থাকে, ইট বিকামস আ প্যালপেবল অবলং সোয়েলিং ইন দ্য অবলং লাম্প ইন দ্য হাইপোগ্যাস্ট্রিক এরিয়া। তো এই ব্লাডারে পেশেন্ট এপাশ করছে ওপাশ করছে, ওভারফ্লো হয়ে যাওয়ার জন্য দের ইজ এ লিকেজ অফ ইউরিন। এগুলো ইয়াং এজে অতটা বেশি হয় না, আনলেস there is some cause of chronic bladder retention in some specific diseases. So these are the three types of incontinence: stress incontinence, urge incontinence, and overflow incontinence. So these are the typical symptoms of a kidney disease. Now, what are the investigations we usually do to diagnose these patients? Number one is urine analysis, that is very important. Number two is blood tests for different things. And number three is the radiological investigations. What do we test in the urine analysis? আগে এগুলো তোমরা বায়োকেমিস্ট্রি প্র্যাকটিক্যাল করেছো, হয়তো দেখেছো, অনেক কিছু টেস্ট করে করে রোথেরাস টেস্ট এটসেট্রা টেস্ট ওয়ার দেয়ার, তাতে বিভিন্ন জিনিস টেস্ট করা হতো। Nowadays the urine analysis is usually done by dipsticks. There are test strips with which 7 or 8 chemical laden paper strips are pasted on that, and by dipping the long strip into the urine sample, through the color change you can assess different things. What are the things that are usually assessed? Number one is pH, number two is specific gravity, number three is blood sugar, urinary sugar, number four is glucose, glucose I already told, protein in the urine, ketone bodies in the urine, urobilinogen or bile salts in the urine, and some other things like ADA and esterases that are not very important. These things are usually tested by urinary dipsticks. That strip is called multi-sticks because it has got multiple reagents. Regarding blood tests, we usually test the urea, creatinine, often blood urea nitrogen, the electrolytes like sodium and potassium. We test microalbuminuria or macroalbuminuria by testing the protein excretion throughout the whole day or in a spot urine. We test eGFR, that is estimated glomerular filtration rate, the creatinine clearance rate. These can all be tested with the blood test. And to test for renal osteodystrophy, we can test the parathyroid hormone and the calcium and the alkaline phosphatase. These things. Regarding the radiological investigations, what we do, the basic thing is renal ultrasound. What do we see in the renal ultrasound? This is very important because it is easily available, it's very cheap, and it's non-invasive. You do not have to put in a catheter or draw some blood or anything. It's totally non-invasive, less irritating to the patient. So usually renal ultrasound is the first investigation that we employ for radiological investigations. We can see the kidneys. Regarding the kidneys, three things are mainly seen. The size of the kidney. If the size of the kidney is less than the stipulated dimension, then there is a possibility of contracted kidney, which may occur due to chronic kidney disease or renal scarring due to reflux nephropathy. There are two other very important things that are seen. One is called cortical echogenicity. In the ultrasound, you flow ultrasonic waves and you assess the reflected waves, and from that you make the picture. So that reflection should be different from the cortex and the medulla. It should not be the same. If some portion of the kidney is damaged and replaced by the fibrosis, then the echo reflection should be the same from both the areas. So that is called loss of corticomedullary differentiation. Loss of corticomedullary differentiation means there is fibrosis in the whole area and there is loss of typical renal architecture. So if the cortical echogenicity is raised and there is loss of corticomedullary differentiation, that indicates loss of normal renal architecture in that area. This is typical of a chronic kidney disease when the kidney becomes gradually fibrous and contracted. We can see other things like renal stones, their position, their size, etc. Any tumor in the kidney or in the ureter or in the vicinity, and any other retroperitoneal structure that is impinging from the outside and causing a obstruction to the renal outflow. Those things we can see. In the bladder, typically we can see any mass, any polyp, any blood clots, any abnormality in the outflow tract, etc. Regarding the prostate, if there is any prostatic hypertrophy, grade 1, grade 2, grade 3, any mass inside or any diverticulum, these things we can see. The urethra, from a very early age, in an infant, in the urethra we can see obstructions like posterior urethral valve. Those are congenital abnormalities that cause bile outlet obstruction, and any other congenital abnormalities that may give rise to an obstruction in the urine outflow. These things we can assess with the USG. What else? We can employ a straight X-ray of abdomen, plain straight X-ray of abdomen, if we suspect a renal stone. There are 5 types of, chemically there are 5 types of renal stones. Some of them are radio opaque. Those can be seen by the X-ray, and the radiolucent stones cannot be seen by the X-ray. But most of them are radio opaque, so you can assess them, their position, their size, etc. by straight X-ray. What else? We can use a CT scan to get a better picture of these whole things. Nowadays, MRI is used in some cases, especially to assess the retroperitoneal structures, and if the patient has got some contraindication to CT scan of abdomen, if there is radiation hazard, etc. Another thing that is very sophisticated and not available everywhere, that is technetium scan. Radionuclide scan we can do, especially to assess any renal scarring. If there is reflux uropathy from a very early age, that reflux uropathy gradually damages the kidneys and they give rise to renal scarring. That we can assess very well through a radionuclide scan. Next thing is not done much nowadays, that is IVP, intravenous pyelography. Intravenous pyelography was a test in which we used to inject a radio opaque dye, and that dye will be filtered out by the kidneys and will pass out through the urine, and by doing serial X-rays, straight X-ray abdomens, we can track the passage of that radionuclide dye and get a whole picture of the whole urinary tree. This is not done much nowadays because the USG does it almost equally like that, and there are radiation hazards. In some cases, there may be anaphylactic shock due to the iodine based dye. So, it is not done much nowadays. One thing that is still done in some cases, that is micturating cystourethrogram. That is, after giving the dye, the patient is asked to micturate, and the way it is going out, that is assessed by serial pictures, and you can get a picture of the lower urinary tract very minutely. You can see any filling defect, any obstruction, any diverticulum, everything. So these are the mostly the radiological investigations, and with all these things we can assess the patient's exact scenario, and with the help of the history, the clinical examination and the investigations, you can almost always come to a typical diagnosis very specifically and take the things accordingly. In renal diseases, one beauty is that except for the carcinomas, almost all diseases are treatable. They have got good drugs, good measures, and you can give the patient a fine symptom-free interval, a good life, and in most of the cases the disease can be cured. That is the beauty. So, in the next class, we will first take up the acute renal failure, which is nowadays called acute kidney disease.